The single most important variable in preventing mother-to-child transmission of HIV is the maternal viral load at the time of delivery. And we had already shown through the Dolphin-1 study that amongst women who initiated antiretroviral therapy in the third trimester of pregnancy, Dolutegravir containing regimens were able to reduce viral load about twice as quickly as the efavirenz-based standard of care. Because of the importance of this finding, we undertook this population pharmacokinetic analysis to seek to understand differences between individual drug exposure and to see whether there were any clinical covariates or factors which might explain differences in drug concentration between individuals and also within individuals over time. In the Dolphin-1 study, women who were on the dolutegravir arm were invited for intensive pharmacokinetic sampling in the third trimester of pregnancy, at the time when they'd been on the drug for 2 weeks, and they were invited back for similar sampling within 2 weeks of delivery, at which time we were also able to sample the breast milk and infant plasma. And where possible, we obtained paired cord and maternal blood samples at delivery. The population pharmacokinetic modelling was done using non-MEM and used a sequential approach whereby the maternal model was developed first and then parameters fixed to the individual estimates for analysis of the infant data. The final model specification is detailed in Figure 1 and shows that we were able to fix a 2-compartment model to describe the dolutegravir in maternal plasma and a 1-compartment model for the infant. There were no clinically significant covariates. The parameter estimates are detailed in Table 1, and Figure 2 shows the visual predictive checks, both before and after correction for the predictions of the model. Following development of this model, simulations were also performed to look at the impact of continuation of the mother on dolutegravir for varying time periods post-delivery. Because in the Dolphin-1 study, the trial design had been that the women changed to the efavirenz-based standard of care after 2 weeks, and so therefore we were able to look at the terminal washout from the different compartments, from the maternal blood, from the breast milk, and from the infant plasma. Drawing all of this together, the major factor influencing infant dolutegravir exposure is the transplacental transfer, with an initial dose estimate of 39.9 milligrams, and the additional exposure through breast milk was considered somewhat negligible. And whilst the infant clearance of dolutegravir is prolonged, it's approximately double that of the adult, and that's expected because of the immaturity of the enzyme UGT1A1. Additional prophylactic coverage to the infant lasts only about 4.5 days and then diminishes thereafter. And should the mother have switched to efavirenz at a later time point, again, the additional prophylactic coverage only really influences those first few days. The strengths of this paper are the richness of the data set and the fact that we had samples from all the different compartments, and the full paper can be accessed through the hyperlink at the bottom. Thank you very much.